Hello, I'm Khairana from Physiology Department, School of Medical Sciences, University Science Malaysia. In this video, we are going to talk about respiratory adjustment at low and high barometric pressure. Let us start with low barometric pressure. As you ascend to higher altitude, the barometric or atmospheric pressure surrounding us decreases. The partial pressure of oxygen in the inspired air will also decrease. At sea level, the barometric pressure is 760 mm/Mercury. At 18,000 feet or 5.5 km above sea level, the barometric pressure is half of that value, which is 380 mm/Mercury. To calculate partial pressure of oxygen in the inspired air at 18,000 feet above sea level, we need to correct the barometric pressure of dry air by the water vapor pressure of 47 mm/Mercury, then multiply by the fractional concentration of oxygen, which is 21%. The fractional concentration of oxygen remains unchanged. So, at 18,000 feet, partial pressure of oxygen in the inspired air is only 70 mm/Mercury as opposed to 160 normally. At the peak of Mount Everest, which is 29,000 feet high, the partial pressure of oxygen is only 47 mm/Mercury. Breathing there is not impossible, but requires respiratory acclimatization or adaptation. The lower pressure of oxygen in the inspired air will lead to a lower alveolar pressure of oxygen and arterial pressure of oxygen. Inadequate oxygenation of arterial blood or hypoxemia will cause hypoxic hypoxia, which is reduced oxygen delivery to the tissues. The immediate response to low arterial PO2 is hyperventilation. If the arterial PO2 is 60 mm/Mercury or less, the changes will be detected by peripheral chemoreceptors at the carotid and aortic bodies. The information will be relayed via the glossopharyngeal and vagus nerve to the respiratory center to increase ventilation. Alveolar ventilation increases to a maximum of about 1.65 times than normal. Because of the hyperventilation, more carbon dioxide is expired by the lungs and arterial PCO2 decreases, producing hypoxemia and eventually respiratory alkalosis. High CO2 will increase hydrogen ions. So if there is low CO2, that means low hydrogen ions. That means a higher pH or more alkali. So that is why when there is hyperventilation, more carbon dioxide is expired by the lungs, there will be respiratory alkalosis. The low PCO2 increase the pH of brain interstitial fluid. This will stimulate central chemoreceptors to reduce the excess ventilation. So, during the first few days at high altitude, mixed signals are being sent. The peripheral chemoreceptors are trying to increase alveolar ventilation, whereas the central chemoreceptors are trying to decrease alveolar ventilation. After a few days, bicarbonate is transported across the blood-brain barrier from the brain to the blood. This causes a decrease in brain interstitial fluid pH. As a result, the braking effect of the high brain interstitial fluid pH disappears, and the peripheral receptors are no longer inhibited from trying to increase alveolar ventilation. So, increase in alveolar ventilation resume and arterial PO2 increase. This partially relieves the hypoxemia that was seen during the first few days at high altitude. Over a few days at high altitude, there is increased excretion of hydrogen ion and bicarbonate ions by the kidney in the urine. So, the pH normalizes. The excretion of bicarbonate resolves the respiratory alkalosis. But the respiratory alkalosis only resolves after about a week at high altitude. Before it resolves, its immediate effect is it will shift the oxygen hemoglobin dissociation curve to the left. If you need help on oxygen hemoglobin dissociation curve, please check out the video on oxygen transport. When the curve is shifted to the left, the affinity of hemoglobin for oxygen is increased. So hemoglobin can pick up oxygen easier in the lungs. Within several days at high altitude, hypoxemia stimulates the production of 2,3-BPG by the red blood cells. So the increase in 2,3-BPG causes the oxygen hemoglobin dissociation curve to shift to the right, which means that P50 increase, hemoglobin affinity for oxygen decrease. So oxygen unloading to the tissues is easier. Within days to weeks at high altitude, chronic hypoxemia stimulates the kidneys to produce and release erythropoietin. Erythropoietin acts on bone marrow to stimulate red blood cell production. And as a consequence, an increase in hemoglobin concentration. The increase in hemoglobin concentrations means that the oxygen carrying capacity is increased, which increases the total oxygen content of blood in spite of arterial PO2 being decreased. Increase in red blood cell concentration, or polycythemia, is advantageous for oxygen transport. However, it also increases the viscosity of the blood, which increases resistance to blood flow. Another effect of low alveolar pressure of oxygen at high altitude is direct pulmonary vasoconstriction, or hypoxic vasoconstriction. Pulmonary vasoconstriction increases pulmonary arterial pressure. Right ventricle must pump against this higher pulmonary arterial pressure, and in the long term may lead to right ventricular hypertrophy due to the increased afterload. Pulmonary vasoconstriction alters the stalling forces, which is high capillary hydrostatic pressure, leading to pulmonary edema. Hypoxic pulmonary vasoconstriction increases the right atrial pressure and releases the atrial natriuretic peptide hormone from the atrial wall to the blood. ANP increases the excretion of sodium and water in the urine, a condition called natriuresis. When adjustment or acclimatization fails, altitude syndromes occur, which can either be acute mountain sickness, characterized by symptoms such as headache, nausea, vomiting, fatigue, and dizziness, or high altitude pulmonary edema, which is fatal, or high altitude cerebral edema, also fatal. All these syndromes have several features in common, and they respond to descent to lower altitude or to supplemental oxygen. In summary, respiratory adaptations to compensate with the high altitude hypoxemia or hypoxic hypoxia occur in 3 stages. Immediately, peripheral chemoreceptors at the carotid and aortic bodies will detect the low pressure of oxygen and increase ventilation. This will increase proportion of fresh air in the alveoli, but at the same time will reduce arterial pressure of carbon dioxide, which will cause respiratory alkalosis, shift oxygen hemoglobin curve to the left, increase affinity of hemoglobin for oxygen, and better oxygen loading in the lungs. Within a few days, there is increased production of 2,3-BPG by the red blood cells, which will shift the oxygen hemoglobin curve to the right and reduce hemoglobin affinity for oxygen, thus increase oxygen unloading to the tissues. Within days to weeks, the kidneys will increase the production of erythropoietin, which stimulate the bone marrow to produce red blood cells. This will increase the red blood cell count and hemoglobin, thus increase the oxygen content of blood. Those are the acclimatization at high altitude or low barometric pressure. In deep sea, the barometric pressure increases by 1 atmosphere or 760 mm mercury for every 10 meters or 33 feet descent. The increased density of gas leads to increased work of breathing. During descent, due to high atmospheric pressure, air-filled cavities are compressed as they fail to communicate with external air. Diving breathing gases commonly used is a mixture of 21% oxygen, 78% nitrogen, and about 1% of other trace gases. At high atmospheric pressure, the partial pressures of these individual gases are also high. High partial pressure of oxygen may cause oxygen toxicity. The symptoms of acute oxygen poisoning include nausea, muscle twitchings, dizziness, blurry visions, irritability, disorientations, and eventually it may even cause seizures followed by coma. Nitrogen is poorly soluble in blood but relatively soluble in fats. Diffuses slowly into the tissues. Nitrogen narcosis is common in deep-sea divers who breathe compressed air, which is air under high pressure. Narcosis is unconsciousness or suppression of sensations. This is caused by high nitrogen pressure on the nerve conduction. Nitrogen narcosis is usually experienced at depth beginning at 100 feet, so divers are usually advised to avoid unnecessary depth. Helium gas may also be used as a substitute for nitrogen to the gas mixture of the compression tank during deepwater diving. Helium has less narcotic effect, dissolves less in the body tissues, and has low density, which will not cause airway resistance. When a person breathes air under high pressure for a long duration, more molecules of gas are forced into solution. With rapid ascent, they come out of solution and form bubbles. This may put the diver at risk of air embolism, which may block major vessels and cause extensive tissue damage. This is called decompression sickness or dysbarism, which is joint pains due to bubble formation in tissues. It occurs when a person returns rapidly to sea level from the deep sea. So to avoid this, divers should ascend slowly and spend some time at different depths to allow nitrogen to return to the blood without forming bubbles. During slow ascent, nitrogen is slowly removed from the tissues because decompression occurs due to decrease in pressure. So that's all for the respiratory changes at low and high barometric pressure. Thank you for watching.